Good day, my dear undergraduate and emerging postgraduate students. I welcome you to today's class with a very famous narrative. There were two women who were taking possession of a child. Both appeared earnest, and as the case could not be solved, it was brought to the notice of King Solomon. After a moment's pause, King Solomon said, "Both the ladies appear earnest enough. So let us divide the child into two and give one half to each of them." Immediately, one of the ladies said, "No, let the child be with the other woman. I want it to be alive." And King Solomon immediately awarded her the child. That is a famous one. Incidentally, what we are seeing over here is the person is about to cut the child and he is holding it in an upside down position. The importance of it we shall be seeing later in the class. What is your diagnosis nevertheless in this case? And today's class shall be about Hirschsprung's disease. The important subjects covered are medicine, pathology, pediatrics particularly. Pediatric surgery has got a lot of role in this. And it is meant for all MBBS students. What next? That is what R.A.T.S is trying to teach us. Definition: Hirschsprung's disease is a congenital anomaly of the large intestine due to the lack of ganglion cells or a marked decrease in their number, either in the myenteric plexus or the Auerbach's plexus, in the submucosal region of the intestine. Because of this, there is a lack of peristalsis, which leads to a functional bowel obstruction. Beautiful words. Functional bowel obstruction. And depending upon the degree of the intestine that is involved, it has been divided into various types. One is called a short segment, which is very common, 70 to 80%, involving the rectosigmoid region. Another is a long segment, proximal to the rectosigmoid, 15 to 25% of the cases. Entire colon can be involved in about 4 to 13%. And the whole bowel, which is extremely rare. These are the different types. So which type is most common, you people should be knowing. What is the basic defect nevertheless? It is the arrest of the cephalocaudal migration from the head to the tail of the neural crest cells along the intestine. The ganglion cells actually provide inhibitory signals for muscle relaxation. So what happens is, in their absence, there is an inhibition for the muscle relaxation, as a result of which they become taut and rigid. This is mediated by nitric oxide. What are we seeing on the screen? I am finding one segment of the large intestine, probably the sigmoid region. The rectum appears normal whatsoever. But then here I am finding it a little rigid, thicker, and then there is a sawtooth appearance that could be made out in this barium enema picture. More important again is the proximal part of the colon, the descending colon. It appears ballooned out or distended. And there is a very vague transition point between the diseased and the normal areas. The ballooned area is in fact normal. This is reflected over here. Thanks to WebPath for this wonderful gross specimen. You find that this is a normal large intestine that is distended, and this is the area that is defective, which is rigid due to lack of peristalsis and thickening of the muscles. Microscopically, we are supposed to make a diagnosis, the pathologist. I find that there is the nerve plexus are there. I find that there are the wavy nuclei of the nerves, but ganglion cells are absent or reduced. Usually, we will be seeing these ganglion cells in between the inner circular and the outer longitudinal muscles. So, this is a muscle bundle, this is another one, inner circular, outer longitudinal. But then, I'm able to see some pale area wherein there are large circular or ovoid cells with eccentric nucleus, pale cytoplasm. These are the ganglion cells, and they can be seen in the myentic plexus or the Auerbach's plexus. The clinical features is, it is seen in the child. Obviously, it cannot be seen in the adult. The newborn also. It doesn't pass meconium for a period of 48 hours. Constipated from birth because it is an inborn mistake. Laxatives are needed. Sometimes you find that there are explosive stools after digitalization or digital evacuation. The same patient can be having features of gastroesophageal reflux. There can be delay in the gastric emptying time, and there is a dilatation of the unaffected proximal segment. So these are some of the features that we people should be having in mind. So what are the investigations that can be done? One of the first and foremost investigations that is needed is the barium enema, which is showing thickening as well as a sawtooth pattern in the affected region. Also, the rectal or the affected to the distended area, the ratio is measured. This shows the degree of severity of the disease. Sometimes it is a short segment, sometimes it is a long segment. Biopsy is mandatory to show the absence or the marked reduction in the ganglion cells. Also, in the normal region, we should mention the presence of the ganglion cells. Both are equally important. And frozen section is definitely needed because the child will be operated upon segments or biopsies are being taken, and then we'll have to declare the presence or the absence of the ganglion cells. Based on which there are three different types of surgeries. One is Swenson, Sow, and Duhamel. Swenson is a pull-through. It is usually done for a short segment defect. The normal segment is pulled down and then it is being sutured. Sow is another one, wherein there is a radial incision in the submucosa. Osteotomy is being done. Openings are being made for the gas to be escaped. And then there is a pull down done as a second stage. Duhamel is another one wherein there is a posterior partial pull through and the anterior part which is defective remains so. So these are the three methods which you people can remember. Your surgical counterparts can be better picks. Swenson, Sow, and the last one. So I find that here it is a pull through. A short segment and the normal segment is pulled down. Here, an osteotomy is being made for the escape of the gas, and once there is a collapse, then there is a corrective surgery that is made as a second step. In the third one, this is the aganglionic segment, the yellow portion, and part of the ganglionic segment is pulled out so that partial peristalsis is there sufficient for the normal function. So this is the basic principle. Excise the aganglionic segment and you suture the ganglionic segment to the distal part or the rectum. At the same time, we should take care that other structures such as the pelvic nerves, prostate, vagina, seminal vesicles, urological structures are all not damaged. Other modes of treatment can be bowel decompression and irrigation. Antibiotics may be needed obviously because there would have been profound infection. So these are the ones. One is osteotomy, and then there can be the primary pull that is there. So this is the picture showing the normal bowel, and then there is a segment which is aganglionic. This is aganglionic, therefore it is appearing stiff. There is no peristalsis. Naturally, the proximal portion gets distended, and this region is showing a reduction in the ganglion cells. The differential diagnosis to be borne in mind can be an imperforate anus. That is what the first picture is about. And the next one is a toxic megacolon, which can be seen in a case of inflammatory bowel disease. That shall be dealt with in a later date. So these two differentials which I'll be having in mind. See, in this case, it is a case of an imperforate anus, in which case when the child is being held upside down, the air collects at the apex, and when an X-ray is being taken, the air cannot escape because the anus is imperforate. Therefore, it is seen as a shadow. This is called the judgment of Solomon position to make a diagnosis of an imperforate anus. See you in what next.